Uh, okay, now it's better. So welcome back, and sorry for the short break. And actually, I'm looking at the program, and it's nice that they built in a Q&A for 20 minutes after the panel discussion. So this way we can have all the time to combine the panel discussion with the Q&A, and as long as we finish before 6:30, because there is another session at 6:30. So welcome again, and for the panel discussion, in addition to the three outstanding speakers and researchers and experts that we had in the previous session, Dr. Hajjeh, Dr. Farhat, and Dr. Talarico, we have additional panelists that I'd like to introduce briefly. Professor Mariette Awad is an associate professor in electrical and computer engineering department at AUB. Her book, Efficient Learning Machines, Theories, Concepts, and Applications for Engineers and Systems, published in 2015, is among the most open source downloaded books for summer 2020, according to Springer Nature. She has more than 100 patents, conferences, and journal articles, and is managing multi-million grants and multidisciplinary international collaborations. She is a founding member of UN ESQUA Knowledge Hub in Beirut and assists in solving central problems related to knowledge management and decision support process in the region. She is a WiDS ambassador, and she has led an AI summer school and founded Women in Engineer Affinity Student Group at AUB and the Women in Engineer Lebanon chapter. Prior to coming to AUB, Mariette worked at IBM, System and Technology Group, where she earned management recognition, several business awards, and multiple patents. So welcome, Mariette, to the panel. Carine Sakr is another panelist for today's session. Dr. Sakr is an assistant professor in the Department of Family Medicine. She joined the American University of Beirut as Director of Employee Health. She earned her medical degree from St. Joseph University in Beirut and her public health degree from Yale University in New Haven, Connecticut. She completed her residency in internal medicine and occupational and environmental medicine fellowship in the US. She practiced occupational medicine and completed research in occupational epidemiology in private and governmental settings in the US. She was also the program director of the Yale Occupational and Environmental Medicine Fellowship Training and lectured at the Yale University School of Public Health. Most importantly, in February 2020, Dr. Sakr was appointed as the chair of the expert committee on COVID-19 at AUB and has been truly heavily involved in the university and medical center's preparedness and response to COVID-19. And we can't thank her enough for all her efforts in the preparation for the management of the pandemic at AUB as a whole. She is an investigator of USAID-funded project at AUB, a nationwide approach to respond to the COVID-19 spread in Lebanon, and has managed to offer training for COVID management to many hospitals in Lebanon and remote areas. And last but not least, I was also told, and very happy to hear that Dr. Ghada El-Hajj Fuleihan is also a member of the panel. Her name is not on the program, but as you know, Dr. Ghada El-Hajj Fuleihan is an organizer for this WiDS conference, and without her help, this session would have not happened. She's professor of medicine and founding director of Calcium Metabolism and Osteoporosis Program and WHO Collaborating Center for Metabolic Bone Disorders, Scholars in Health Research Program at American University of Beirut, Lebanon, and she's one of the most outstanding physician scientists at AUBMC, and we're very proud of Ghada. So I think what we're gonna do is take some questions from people who are following, and I'm gonna keep my eye on the chat box. And meanwhile, there are a few questions that we have prepared. And I'd like to start with Dr. Sakr. And as I mentioned, she's in charge of the occupational health program at AUBMC. And as you can imagine, this has been really a tremendous challenge to cope with all the employee exposure and management of what do you do with these employees in terms of disposition and tracking their exposures. So the first question for Dr. Sakr is, what were the challenges faced to maintain adequate level of staffing at AUBMC during the pandemic? If you can share your thoughts on that.
Okay. Well, thank you very much, Dr. Kanj, for the introduction, and thank you for the opportunity as well. Will I be able to share my screen? I just wanted to show a few graphs. Is that possible?
Yes, Hani, can you give Dr. Sakr the right to share her screen, please?
Okay, and while I'm, okay, here we go. Let's hope I can do this. So while we were you can see my graphs here.
Yeah, but Dr. Sakr, please, if I can ask you
Sure.
to look at the top left-hand side, there's a display setting.
Yes.
Because now we can see your next slide as well. So from here, yeah.
That's okay.
Thank you.
We're good now?
Yes.
Okay, so then I have to move my camera. Okay. So as Dr. Kanj was saying, we were heavily involved in doing risk assessments for our exposed healthcare workers during this pandemic. As everybody knows by now, healthcare workers are at increased risk for COVID-19. So, and the reason it was challenging was because all of a sudden you have people who are exposed and you want to make a decision on what to do.
Dr. Sakr?
Yes.
Apologies to interrupt again,
Sure.
but there's a box open. We cannot see the content of it. It might be the chat box. It's on the right-hand side of your screen. So if you just close that so that there's nothing in front of your screen, because you can see a gray square box.
Did it go away?
Yes.
Now.
Perfect.
Thank
Okay.
you. Apologies again.
Okay, no worries. So, and as Dr. Françoise was saying and Dr. Rana Hajjeh was saying, they were talking about breaking the silos, and this is exactly what we were doing. We were working with our infection control colleagues, with our quality colleagues, with the nursing department, and all of a sudden everybody was doing risk assessments with us, trying to identify who were the exposed employees, how significant was the exposure, etc., etc. So the first case in Lebanon was in February 2020. The first case among our workforce at the AUBMC was in March. And the first exposure risk assessment that we did here was in March. And as you see on the slide, we had most of the employees had low risk exposure. April, we did some risk assessments as well. Things calmed down in terms of pandemic. And unfortunately, in August, especially after the explosion, the Beirut blast, the community transmission increased significantly. So risk assessment is done mainly when community transmission is low. Here's the numbers for July. You can tell, for example, that we had roughly 300 people who had low risk exposure, less people had high risk exposure. So the challenge here is, okay, so what do you do with these employees? Who stays at work? Who do you send home? And we were following the guidelines from the WHO and the CDC. However, the guidelines were even changing, and we had to follow up on this. So in July, for example, we had to send home 500 healthcare workers, less in August. And if you can look at the number here, it's not the same scale. The blue line is the one that you were seeing before. That's the number of employees sent home, which was close to 150. But in terms of lost days, we are talking something close to 1,200 days. So 1,200 days of lost work days, basically, because these people were sent home because we were concerned about their exposure and we were concerned about the risk of transmission. So this was all happening when the pandemic numbers were pretty low, in Lebanon. And the other challenge was to identify who was getting exposed from the community, who was getting exposed in the hospital. So in the beginning, we were able to tell, and then it became very obvious that most of the transmission was community exposure, or people just did not know. And I think the most telling story from the numbers here is when we looked at community transmission, as I said, things picked up in Lebanon, and the blue curve is AUBMC, the orange curve is Lebanon. Obviously, the scales are different so that I could put them on the same slide, but you can tell how close these two are. And the things picked up, as we said, after August explosion, and again, after the end of the year holiday season, you can look at the curve, but it tells you how close these two curves were and how our population was really mirroring what was happening in the country.
Thank you very much, Carine. And as you said, in many of these exposures, it was impossible to tell if it was a hospital exposure or community exposure. A question for Mariette. I think in a country with huge economic crisis and we have limited resources to hire more employees, and this was the case in our setting where the hospital laid off several hundred, 800 employees. So we need to find ways to depend less on humans and more on artificial intelligence, perhaps to guide us. So how can we use artificial intelligence in modeling for COVID-19? You're muted, Mariette. Yeah.
Sorry. Yeah, so AI can be very useful, and probably in Lebanon we need it more because of the economical meltdown that we are experiencing. But even I think worldwide, the wonderful and amazing information and the presentations in session were shared, we can see the impact and the importance of how AI had helped. So for Lebanon, and again, for probably in the South, AI can be very useful, and in the three terms, basically, for short term, for medium term, and for long term. For short term, for example, if you want to study the occupancy rate, if you would want to look at some, I'm not sure if the echo is from my side. Now it seems to be. So technically, if you want to identify high-risk patient, if you really to do some screening, temperature, smart apps to look for spread, leveraging geospatial information, come up with these risk calculators, understand who should be entitled for vaccines, for medium term, for example, and what's the potential of therapeutic options that we have. For long term, really trying to see how we can make cities safer for the future. AI can help Lebanon and also worldwide in these management projects.
Thank you, Mariette. Also, okay, so with the number of COVID-19 patients we were seeing, at some point the emergency rooms were really totally loaded with patients, and as you can imagine, many of these patients require CT scan imaging, etc. And the radiologists were getting swamped reading those CT scans. Can you foresee a role for AI, machine learning, reading CT scans, for example?
Yes, definitely, Souha. This is something image processing and deep learning can offer the medical community. So doing some automated CTs and helping in the triage, this could help a lot. And also, it has been used a little bit around the world, some chatbots. So these chatbots would be some, software where the population, and it's based on natural language processing. They can even further direct, the patients, diagnose their symptoms, because, for a long time, people were confusing the symptoms of flu with COVID. So definitely at the level of the imagery, at the level of assisting and the triage, directing, providing information, AI through machine learning and through image processing, deep learning, through natural language processing can help.
Yeah, thank you, Mariette. I think there's a comment more than a question by Niveen. Niveen is concerned that if we use AI more, we're gonna let go of more employees, which will leave more people without jobs. I don't think that at all. Just to make the operation more efficient, I think so. Yeah,
yes,
thank you, Mariette.
And I want these people to be, even if you want to think about it, you can use robotic tools and tiny robots to clean up. Think about AI as long as it's well, and controlled, implemented. It's there really to offload probably the not very attractive tasks, and we would like the healthcare workers to focus more and stay healthy, especially in pandemics like the COVID-19.
Thank you, Mariette. I think Maha has a comment about AI. Maha, go ahead.
Thank you, Souha. I just, as someone who sits in the biomedical informatics department, we definitely do think a lot about how you can integrate machine learning into clinical practice on a daily basis. We've developed models and also kind of collaborate with people who do image processing. And I just want to say that I know that the machine learning in healthcare generates a lot of discussion, both positive and negative, because of potential concerns about, for example, discrimination, concerns about accuracy, concerns about transparency, concerns about people losing their jobs, as an audience member mentioned. So my viewpoint on this, as far as how machine learning could be integrated into healthcare. Well, one, it requires a lot of data for you to train these models well. And I think that we still, correct me if I'm wrong, at least in the MENA region, we're still working on digitizing our health data. That's not necessarily a reality in many medical centers. And so that's sort of important that we develop models that are potentially portable and usable and accurate in our population. So that's sort of a big consideration. There's also, considerations about, people understanding what these models are doing and what their role is in current practice, right? I echo what Dr. Awad said, and I think the key places where there's going to be space for them is going to be in, for example, that X-ray that you're reading, maybe screening out things that are clearly normal so the radiologist can focus on the abnormal. Or, for triage, right now, at least in the US, where a lot of electronic health record systems are set up, you have these pop-ups that all physicians hate that tell you things like, oh, be careful, you have a patient that has, a higher risk of readmission when you're writing a discharge summary or something like that. So you can kind of be aware or make sure you set up their follow-up properly. it's really like an augmentation, not necessarily a replacement in the grand majority of cases.
Thank you, Maha. I think Victor Araman has his hand up. Victor, would you like to ask your question? You can unmute and ask your question. Victor? Okay, so perhaps his hand is up by mistake. We'll come back to it if Victor can hear us. I have a question for Rana, Dr. Hajjeh. First, thank you for sharing the data. It's truly overwhelming to see how much data you've been able to collect in just short of 1 year. So the question I have for you is, how can we ensure that statistical analysis of COVID-19 trends are really accurate, particularly in our region where we have significant discrepancies? We have countries like UAE, for example, where you have a lot of resources and data collection. And on the other extreme, we have Yemen and Syria, where screening is not being done regularly. So question for Rana Hajjeh, what can we do to ensure that we have more accurate data?
Yes, thank you, Souha. I mean, this is a very important question. It's actually, it can be a talk by itself because, we live in a region with a huge spectrum of both resources, socioeconomic development, as well as healthcare and health infrastructure capacity. So we have even in some of the in some of the richer countries, it hasn't always been the high priority to focus on health systems. As Maha mentioned, I mean, actually, most of the countries now that are middle to upper level in terms of development have developed, for example, electronic medical records. But even in some of these countries, it's just starting. Like, as you know, in Lebanon, there's only very few, mostly some of the large academic centers that have, have electronic medical records, etc. But at the level of the, government, the Ministry of Health, the data infrastructure is still relatively weak. I mean, we still have many countries in our region that rely on paper data. I was surprised when I was going around last year. There's still, like labs, the labs report their data on a piece of paper, and then they have to send that piece of paper to the Ministry of Health so the data can be together compiled with the surveillance data. I mean, so we have a lot to do in terms of developing health information systems that are electronic systems. That's first, and we are, for example, one of our big initiatives this year is to we have a paper for our we have these annual meetings for all the ministers of health in October, and one of our major papers is on developing integrated disease surveillance systems for the region. So this will be, all countries will have, and there are various models around the world that some of them are more sophisticated than others, but some of them would easily fit countries of that are in the low-income countries. The other thing I would like to mention, I didn't have, it was in my slides, but I didn't have the time to talk about it, is the need for more epidemiologic and statistical human resource capacity. This is not a skill. I mean, I'm biased, I'm an epidemiologist, but this is not a skill that has received a lot of focus in our region. We have these huge amount of data sometimes in the countries, but they cannot analyze them. So we need to go in parallel developing the actual systems and developing the human capacity in terms of certain skill sets that were really in shortage in many of our countries. It's a lot of work, but we need that high level commitment, because without the high level commitments, you cannot start working on country-wide systems and start doing a lot of training, putting the right electronic infrastructure in place, etc.
Yeah. Thank you, Rana. I think at the beginning of the pandemic, I was putting a talk together for COVID in the Arab countries and case fatality rates. And the case fatality rates in Iraq and Yemen were 20%, 30%, but it turned out they were only screening those very ill patients, coming to the hospitals and ICU. And so we have to be really very careful, as you said, about how we interpret the data for the countries in the region. So
maybe I can have just one quick comment on this issue, because in most countries, as you mentioned, it was really a denominator issue because the denominator was mostly the severe cases. But I have to say, we have still few countries in the region where they are very short on critical care units.
Yeah.
They don't even have enough physicians who are trained as either pulmonary care or critical care actually specialists. So again, some of the high, maybe it wasn't as high in 20%, but in few of the countries we had mortality rates over, at least 2 or 3 times the average rate in the world.
Thank you, Rana. A question for Carla. Carla, can you hear us?
I can hear you. Can you hear me okay?
Yes. Yeah, thank you again for your excellent talk. So I want to ask you a question. Can you elaborate on plans to collect individual data, for example, using mobile apps, including demographic, race, age, comorbidities, etc., of those patients who received the vaccine to try to determine if there were some predictors of the effectiveness of the vaccine?
Sure. So I think briefly I can touch on 2 topics. So one is related to the effectiveness study that I described. So one piece I didn't go into is actually for individuals who are in that study and who turn up with a positive SARS-CoV-2 test, right? So we are going to collect the specimens from all of the vaccinated individuals, and then also from a sample of the unvaccinated individuals. Because what we want to know also, of course, I mean, the effectiveness of our vaccine is directly related to, what strains, if you will, are circulating, in the community in which it's deployed, or in the population in which it's deployed. So I think that's going to be one element, is we are going to embed getting sequence data out of that large-scale effectiveness study, where we then can integrate it also with the other kind of clinical metadata that we were talking about. I think the second piece that this is a plan that we're just looking into right now, is to try to partner with one of the pharmacy chains in the US that's quite common. Because one of the places that most people have ended up going to get their COVID test are your local pharmacy. So actually our pharmacies have ended up with this massive amount of data, and then can actually, because they're pharmacies, they can link to some patient level data in terms of their comorbid conditions, what medications they're on. So Moderna is trying to also set up a partnership with one of our national pharmacy chains in order to basically kind of have like it's almost like a surveillance system, right? Where we're getting these regular updates, again, to try to not be, kind of scanning Twitter and GSI, looking at GSAID every moment, to try to standardize, at least from the US, what is happening, in terms of variants and circulating, and what's happening over time.
Yeah, thank you very much, Carla. So I think we're all aware of the fact that we've been bombarded by information. I think it's been so hard to keep up, but also we've been bombarded by misinformation, misinformation coming from social media, TV news. And a question for Maha: what is the role of data science in battling misinformation in a pandemic such as COVID-19, for example?
Thank you, Souha. I think that there is definitely a big role that we can play as a public health and data science community. I think we have potentially the resources more than anyone to be able to share data with others so they can validate and confirm. There's a burgeoning community of, millennials able to process the data for themselves that are able to then post-analyze and reanalyze the data. Not that I'm necessarily advocating for amateurs to work with the data, but I think, and try to become, what we call, what was it? Epidemiologist. Thank you, Carla. I think we watched the same Twitter feed. But I think that there is something to be said about sharing data, putting analyses out there in the preprint form so people can read them. Of course, you will always need experts, but there is really a role to share tools in an open way, share data in an open way. And that, I think, is our biggest, potentially biggest weapon against misinformation. But I think also that scientists, pharmaceutical companies, people in the industry, experts, but then I was touching on the lack of expertise, but the people who have the expertise, these are the people who need to step up and speak and battle misinformation. We can't sit in our little shells and pretend that somebody's going to tell the community that vaccines are good, or this person who's saying that vaccines are harmful or experimental, or who can't really process the data on the importance of the vaccines can is just going to go away. In fact, it's not. Like, it's really our role as experts, as scientists, and as citizen scientists, hopefully in the audience who are kind of burgeoning scientists, to go out there and say what is what's accurate, what's not accurate. And it's really an interesting evolution. Typically, scientists are quite siloed. Academicians are siloed from their community. They're kind of up on this ivory tower. I think with social media and this sort of globalization that we're experiencing now, and everything getting digitized, is that scientists are kind of holding the mic and trying to speak out more. And I think that's a good thing. And I think it's because also how much, it's true, these forums give mics and give airtime to everyone. And so we can't just, the people who know the answers or have at least a good sense of skepticism on what we should believe, really should be more vocal. And I think that's really something we've learned the hard way this pandemic.
Yeah, I think this SARS-CoV-2 infection has really put the spotlight on the importance of having a multidisciplinary conversation, on a daily basis between the epidemiologist, the molecular biologist, the biostatistician, the occupational health, the physician, the clinicians, etc. So, and we've seen that in many academic centers. So in a way, that's the only positive outcome of this COVID pandemic. They just built the spirit of, having a multidisciplinary approach to an infectious disease. I still have Victor's hand up. I'm not sure if you can hear us, Victor, to ask your question. If not, I'd like to pass the microphone to Dr. Ghada El-Hajj Fuleihan if she'd like to have an intervention here. Victor, can you hear us? Victor, but go ahead. We all understood it except Carla, maybe. Victor, would you like to say something?
He's probably on the phone.
Okay. Okay, you lost your chance, Victor. Dr. Ghada El-Hajj Fuleihan, are you with us? You'd like to say a few comments or ask questions?
Yes, thank you, Souha. I want to really thank an outstanding panel of speakers and panelists. This is an amazing session. I'm already making plans for it to be delivered in different forums. It's really very inspiring. I'm very intrigued by the power of AI and machine learning. And as Mariette knows, we've been talking a lot about how can we make the best out of this. We have very scarce big data in the Middle East, in general, Lebanon in particular. But I was curious to hear from Carla, what are the plans, if any? And it sounds counterintuitive to the pharma philosophy in biotech companies for merging big data to better understand resistance, anaphylaxis, so on and so forth. It sounds utopic, but I think the viciousness of this virus makes me believe maybe we should start thinking about data sharing between big companies.
So this is a fantastic question, and I can tell you that I think we're not there yet in terms of, I would say, getting to a point where data is directly shared or merged or aggregated between companies, right? So so for example, there might be, you could make an argument where you have, COVID vaccines of a similar platform. So like the Pfizer mRNA vaccine and Moderna's mRNA vaccine, right? Could there be a benefit in areas where there are limited data to pooling those together? I would say, right now that we're not there yet, unfortunately. And I think there is some argument also to be said, because even though they are both mRNA platforms, are some differences to them. I could also, the one thing that I did want to, I think I hear Victor, I don't know what he's saying, it's true, but I think he's in the background still. But the one thing that I did find very encouraging as in this pandemic, in terms of cross sponsor or cross manufacturer work, when it came time for harmonizing protocols for observational post-authorization safety studies and effectiveness studies, or deciding what are we going to measure, what kinds of safety outcomes are we all going to monitor for, right, after these vaccines are rolled out and on a large scale. There really was, it wasn't always the most organized, right, but we got there, right? There really was a concerted effort between the companies to come together so that, for example, regulatory authorities don't need to see 5 similar safety study protocols, 5 similar effectiveness study protocols, right? We're like, okay, can we make all of our lives easier so this all goes more quickly? On a kind of a funny note, it did turn out that the lead epidemiologists from Moderna, Pfizer, J&J, and AZ, all working on COVID vaccines, we all used to work together. So I don't know if it was also part of a networking. We knew each other, and we all have a very much kind of a public health view, a public health lens. So we knew the benefit of coming together on at least, what are we going to measure? Can we have some harmonized protocols? When it comes to the data piece, I have to say, we're in full transparency, we're not there yet. Ooh, I think you're on mute.
One other quick question, if I may. On the Kaiser Permanente database, you're going to follow them, you're going to be able to correlate with clinical variables, but there is a lot of interference in an observational studies of other co-intervention, other things happening. So it's not going to be as pure as, 2 doses, let's see what happens over the long run.
Yeah.
Do you have any thoughts on that?
Oh, absolutely. Absolutely. I mean, that could be that I could go on and on about that, because that's good stuff, right? But I think long story short, there are ways that we are going to match on certain key variables at the beginning of the study. So in the design phase, right? So our vaccinated and unvaccinated, and we're going to try to, with the goal of trying to make those 2 groups as comparable as possible in the real world, right? So they're like age, sex, I'm blanking. See, now I'm blanking.
BMI.
Yeah, a risk score, basically a risk score for COVID, which takes into a lot of things, a lot of variables behind it. But then on the statistical analysis side, we also have plans to do things like propensity score matching, right? Because there are, as you said, there are just going to be so many variables, right? From comorbid conditions to your occupation, right? That all of that is going to have to be somehow taken into account and quantitated. It won't be perfect, but we're going to use all of the kind of statistical tools that we have at our hands to try to make those vaccinated and unvaccinated individuals as similar as possible.
But the unvaccinated may get vaccinated. That's what I'm talking about. So no matter what you match at baseline, you're going to be finding,
It is true. It's actually a dynamic cohort study where we allow the unvaccinated to get vaccinated. So, and then there's a whole other piece about how we change our matching scheme and the way we're, matching. So we could talk for a long time, and happy to.
Thank you.
Thank you, Ghada. Thank you, Carla. So we have 5 more minutes, so we're gonna ask questions, and if we can have short answers, starting with Carine. Carine, was the data collecting on healthcare worker infection helping you develop policies, like particularly when we had clusters in certain departments? Carine, can you hear us?
Sure. Yeah, I can hear you. Yes, for sure. So when we were tracking cases among employees, we were looking at them by department, and every time we saw a signal like one case and then another one 2 days later, and then a third one 3 days later, this is when we were really getting concerned. And we also, when we were doing all these interrogations, we figured out, for example, that lunches were a major risk factor. So we recommended people not to have lunch together. For example, that was one example. And when we also looked at smaller departments, we looked at ventilation, we looked at occupancy, we had some concerns about areas being poorly ventilated, and we had some concerns at this point, especially that the CDC was saying, well, maybe there could be some aerosol transmission in certain circumstances. So we raised that flag as well. So definitely policies change, and recommendations on like work behaviors came into play also.
Okay, thank you, Carine. Mariette, I'm going to ask you 2 questions. If we can have brief answers. So what are the challenges of mathematical modeling for vaccine accuracy in the setting of new variants?
Sure. When we talk about modeling and using AI tools, as it was mentioned earlier by Maha and throughout this talk, data is king, and this availability of data on the different populations, bias on the different type of vaccines, really, because AI, whenever we're gonna use them, they do rely on data, and because they're like more like data driven. So I would say one of the most one is data.
Okay, and in terms of adopting the AI predictive tools and the time scale interventions, how do you foresee this happening?
Can you repeat? Sorry, I had a
So
little bit of
what are the challenges for adopting predictive tools in the different time scale interventions?
Sure. I mean, every time scale intervention has its own challenges. I think the common denominator for these different scales would be the acceptance and openness of the community. So we just had a couple of comments from the audience here about the ethics, about how much do they trust, how much transparent, how much interpretable these machine learning models are, because as you know, they are mostly like black boxes. So there has to be some faith in AI predictive tools. At the same way, I think as a community, other than having more data sharing, there has to be some good and regulations for patient data now that we have hit this amount of mega data during pandemic, to preserve really the patient privacy, at the same time use it for the better for the community.
Thank you, Mariette. Question for Rana. So Rana, I think WHO has really done a humongous effort, but do you see a role for NGOs and academia, etc., in terms of having a stronger data system?
This pandemic management, Souha, has been beyond just the health sector. You were asking earlier about how to combat the infodemics and the misinformation. And I think maybe it's not just a data issue per se, but it's an engagement of the community sectors. This is actually one of the areas where we did not have good data. We did not have information on all the community influencers. So this is when we talk about the whole of society. I think this is during this pandemic, this has been more critical than ever. And I think moving on, actually, with the second year, we don't know how long. I mean, this is probably going to become like influenza, where it comes on, and there's a seasonality or returning seasons of COVID. I think the role of the community overall, and this is beyond health, beyond academia, beyond all the other sectors, because the media sector by itself, I think, has a major responsibility. I mean, we keep talking about collective responsibility. The media has to be disseminating the right data and the right information. The media has to select. I've been watching a lot, and I've been on many of these news channels. I'm very selective now because some of them, they just want to fill the air, as was mentioned, or they want to incite, discussions, or sometimes there are many other agendas. And we really need to call on all the media in particular, and the community, the community members, to be more socially responsible in terms of using the data that is there, even within the medical community and the health community. I think we have to be very responsible on the air and giving messages that were not always correct. And, in the medical profession, we took the oath to do no harm first, before even doing anything good is doing no harm. So I would end really wanted to send the message. I mean, first, that this has been an amazing session, but to send the message is like how to continue to use what the data has told us over the last year, that vaccines alone are not going to curb the transmission of the pandemic, and we need to really measures that the data have proven are quite effective. So thank you.
Thank you. Thank you very much, Rana. I think it's time to wrap up the session to stay on time, because there is also one more session that Mariette needs to start in a minute. So I'd like to really thank all the panelists and the speakers for their outstanding presentations and participation. And again, I'd like to thank the organizers for giving me the honor to chair the session. Thank you very much. And Mariette, it's the microphone is over to you.
Thank you, Souha, for this. Actually, the session is in another, it's on another link. I think we need to close. First, I would like to thank you, Souha, and all the panelists for a wonderful, wonderful session. Even as someone without a medical background, it was extremely informative and extremely relevant to everyday life to us, and it kind of like enlightened us so much more about what is happening and how are these studies done and conducted. Thank you so much for these panelists, and also for the panelists from the business session. It has been a wonderful, wonderful experience. Lama, I just want to say that we're moving now to a session that is dedicated to AUB students, a Facebook recruitment session that is moderated by Professor Mariette, Awad. But before that, I would like to just pass on to Dr. Lama, if you'd like to say some thank yous and quick closing remarks.
Thank you, Lina. Thank you so much for the outstanding health session. Thank you, Souha. Thank you for the speakers, panelists, and Professor Ghada for organizing this wonderful session. So to close quickly before we move on to the third session, it's a different link again for AB students. I want to say a few thank you for the team that made this possible. I want to start by thanking AUB leadership, President Fadl Khouri. I want to thank the OSB interim Dean Yusuf Sidani, the wonderful speakers and moderators that were with us today. I want to thank also the WiDS team at Stanford, and the WiDS ambassadors, Dr. Lina Dao, Ms. Rasha Bouhsari, thank you so much. I want to thank the organizing team. Professor Ghada El-Hajj Fuleihan, she put amazing effort in bringing together of this wonderful health session. Thank you so much. I want to thank the WiDS coordinator, Ms. Layan Sarkis. Thank you so much for working days and nights in the last 2 weeks. I want to thank the support of OSB, the operations manager, Abir Sinno, for the great support, and the amazing staff at OSB, Aya, and Rima. I want to thank the OSB comms team, Yara and Diana, thank you very much. The AUBMC team, the executive director, Ms. Fida Kanaan, the IT team, thank you so much, Hani and Dania. And now we move on to the next session, our third session. Please use a separate link. We sent you a separate link for those who will be attending that session.